Okay, it's 7, so let's begin. So welcome everyone. Thank you for attending today's Gutsy Learning Series event on understanding your diagnostics in IBD. My name is Rashane, and I am the Manager of Research Grants, Impact Communication and Evaluation at Crohn's and Colitis Canada, and I will be the moderator of the event today. So before we kick things off, let's go over some updates and technical details. So the session is offers audio and video in both English and French. Select in the menu bar below, you can see that there's the world icon with the word interpretation, with the label interpretation. So if you click that, you can select the language of your choice, so either French or English. And at the top, you'll actually also see 2 tabs, French and English. So again, pick the tab of your choice. If you encounter any technical issues, try refreshing your website browser or restarting the webinar. Alternatively, you can also share any concerns in the Q&A box, and we'll try our best to get to you during the seminar. Next, I'd like to acknowledge the rich history and heritage of Canada's Indigenous people. While we meet today on a virtual platform, we recognize the importance of the lands which we call home. From coast to coast to coast, we acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nations people that call this land home. Through this acknowledgement, we express respect for the traditional territories of the Indigenous communities and contribute to the promotion of reconciliation. Next, I'd also like to issue a disclaimer. The content presented in this presentation by Crohn's and Colitis Canada is intended solely for educational purposes. While the information holds general value, it may not be applicable to specific medical situations. Online resources should not be seen as a substitute for personalized judgment and care provided by a trained healthcare professional. Crohn's and Colitis Canada does not endorse any external product or service mentioned during this webinar. For those of you joining us for the first time, allow me to share Crohn's and Colitis Canada's commitment with you. Our organization is dedicated to discovering a cure for Crohn's disease and ulcerative colitis. Through research, education, awareness, and advocacy, our organization strives to enhance the lives of everyone affected by these chronic diseases. Next, I want to briefly go over some programs that are available for our community. So if you are someone or you know someone living with Crohn's disease or ulcerative colitis, we invite you to explore our Crohn's and Colitis Connect platform. This is essentially an online community that offers everyone, individuals with lived experience, the opportunity to engage with each other about challenges that they face living with IBD. And we hope that the platform provides a safe space for advice and understanding. We also have some sessions that are coming up at Crohn's and Colitis Canada. We have a caregiver group peer support event that's taking place on June 3rd. So please feel free to look into it. And next thing is, before we begin our session, we will conduct a really quick poll just to see where everyone is with their understanding about this topic. So you should see that on your screen right now. And I'll give everyone about 30 seconds to answer the poll. Okay, awesome. Thank you for taking part in that. And so now we'll proceed to our main event. But before we begin, let me briefly introduce Dr. Seth Shaffer, who is our speaker for tonight. So Dr. Seth Shaffer completed his medical school at the University of Manitoba and then went on to Queen's University for his internal medicine training and returned to Winnipeg to specialize in gastroenterology. He then completed a fellowship in IBD at the University of Chicago, while also gaining his master's in public health sciences, with an interest in health economics. In 2020, Dr. Shaffer joined University of Manitoba as an assistant professor of medicine and is currently practicing as a gastroenterologist at Health Sciences Center. He is also a member of the University of Manitoba IBD Clinical and Research Center. His research focuses on understanding the causes and clinical management of persons with IBD and the economic impact of caring for patients with IBD. So really like to thank Dr. Shaffer for being with us here today and for taking the time to share your expertise. We really look forward to this meeting. Now I will pass on to Dr. Shaffer, so please go ahead and share your slides.
Well, thanks so much for that lovely introduction. Can you can see everything okay?
Yes, looks good to me.
Okay, great. So thanks everyone for joining, and we'll be discussing diagnostic testing in IBD. And here are the learning objectives. So first off, we'll discuss the different tests that we use to diagnose and monitor people with inflammatory bowel disease or IBD. Second, what to expect during these procedures. Third, understanding these results and questions that should at least be discussed or asked of your provider. And fourth, we'll briefly touch upon precision medicine for personalized treatment when treating IBD. So I want to briefly discuss IBD and give a bit of an overview. And I'm sure everyone here knows this, but for those who don't, inflammatory bowel disease consists of both Crohn's disease and ulcerative colitis. And there can be overlap between these two diseases. Now, for whatever reason, there's inflammation in the gastrointestinal tract. Sometimes that's a good thing. So if, let's say, you ingest some food with bacteria or the food's rotten, you want your immune system to attack that bacteria. And so what'll happen is there's inflammation somewhere in the gastrointestinal tract. You may get symptoms of diarrhea or pain, and eventually the infection should go away, sometimes with antibiotics, but maybe without antibiotics, the infection goes away and the inflammation turns off. The problem in inflammatory bowel disease, though, is there's no off switch. So the inflammation starts and it keeps going. And we're not entirely sure why that happens. We know that there's a genetic predisposition. So we know that in people with Crohn's disease or ulcerative colitis, the risk to family members is higher. Now, it's not 50% like hair color or eye color, but it is elevated. So there's some sort of genetic predisposition. And we think that environment plays a role and diet as well. And we're not discussing diet, that's a whole other topic, but we think the combination of all of this likely leads to this inflammation starting. Now, the difference between ulcerative colitis and Crohn's disease sometimes is obvious, but sometimes it's not. And like I said, there can be overlap between the two. Ulcerative colitis, like the name suggests, is just in the colon. Colitis means there's inflammation in the colon. And 95% of the time, that starts in the rectum and it moves upwards. And it just affects the gut lining. Whereas Crohn's disease can affect anywhere from the mouth to the anus, and it can be patchy. And the difference is that the inflammation can go through the bowel wall. And when that happens, there can be other things that occur with this chronic inflammation, and you can get what's called a fistula, which is an abnormal connection or tunnel between two adjacent organs. So that can be between the bowel and the skin, or between two loops of bowel, or other organs. And bacteria from the bowel can then leave through this tunnel, and there can be infections or abscesses. So these two diseases, like I said, have some overlap, but they are a bit different, and that'll lead to the testing that we'll discuss about later. The other thing I wanted to mention is that even though we label things as Crohn's disease, or someone may have ulcerative colitis. In reality, there's a lot of different phenotypes. And what I mean by phenotypes is the presentation of the disease can differ between many people. Some people have very mild disease their entire life. Other people can have severe disease. And some people with Crohn's never get any fistulas, whereas other people may. And so in reality, there may be many different types of diseases. We just term it as Crohn's disease. And as I mentioned, there's different types of Crohn's disease, and the most common area where Crohn's disease affects is the end of the small bowel, and that's the ileum. And it can affect just the ileum, the end of the small bowel. It can also affect the ileum and the colon, and that would be ileocolitis. It can just affect the colon, and that can be very confusing sometimes because it's Crohn's colitis or Crohn's disease of the colon. And it sounds very similar to ulcerative colitis, so it can be confusing sometimes. And as I mentioned, people can also have fistulas, and it can either be in the abdomen, it can be in the perianal region. And when that occurs, it's termed perianal disease in Crohn's disease. So I want to give a little shout out to the Impact of IBD in Canada report, and it was sponsored by Crohn's and Colitis Canada, and I was lucky enough to be involved in compiling this report. And why I want to touch upon this is because the incidence of IBD in Canada is really increasing. You can see in 2018, 0.7% of people in Canada had some form of inflammatory bowel disease. And by 2035, it's expected to increase to just over 1%. Now, the incidence is increasing, and because we have good treatments and people aren't dying from Crohn's disease or ulcerative colitis, the number of people with this disease is increasing as well. So as more people are being diagnosed, there's more people in Canada with this. So the incidence is increasing and it's becoming ever more prevalent. And for that reason, I think awareness is really increasing. And this report really highlighted the importance of healthcare policymakers being aware of this. So we see that 1 in 5 people with Crohn's disease and 1 in 8 people with ulcerative colitis are hospitalized every year. And 1 in 3 people with Crohn's disease unfortunately need surgery within 10 years of diagnosis. So it's certainly something that is a chronic disease, and there's always a risk of hospitalization and or surgery. And that's why it's so important that this report came out a few years ago. Now, what symptoms do people have when they
sorry about that. I think Dr. Shaffer will join back quickly soon.
Sorry about that, guys. Can you hear me now?
Yes, we can hear you.
Okay, you can see my slides?
Yes, we can see your slides.
Okay. Okay. So how do people with Crohn's disease or ulcerative colitis present? What symptoms do they have? And this is also important because there's a wide variability of how people initially are diagnosed. Some people may not have any symptoms, and sometimes it's just found upon incidentally, sometimes on endoscopy if they're having it for other reasons like screening or colon cancer. Other people can just have blood work abnormalities like low iron or iron deficiency. And again, people feel well and have no symptoms. Alternatively, people can have significant symptoms, as I'm sure people here know. Diarrhea with or without blood often is seen in both ulcerative colitis as well as Crohn's disease. Urgency, where people have to run to the bathroom to have a bowel movement. People may wake up overnight to have a bowel movement. Abdominal pain, they may lose weight. And then, as I mentioned in Crohn's disease, people can get perianal symptoms. So they can get fistulas, occasionally abscesses, sometimes anal fissures, and other symptoms there. So there's a wide range of symptoms that people can have. And it's important when we discuss the different testing, how each of these come into play. So next up, we're going to look at the different diagnostic tests for inflammatory bowel disease. Now, I'm sure everyone here has had blood tests at least once in their life, and it may be different from what we're looking at when we're trying to assess for inflammatory bowel disease. So blood tests are good because it's an easy way to assess the complete blood count, and if the hemoglobin's low, that means someone has anemia. Ferritin is a marker of iron stores, and if the ferritin's low, that means someone may have iron deficiency, or likely does. Albumin is often used as a marker of both nutrition and chronic inflammation. And C-reactive protein is a marker of inflammation in the body. So if there's inflammation, the C-reactive protein, or CRP, often is high. Now, not everyone with Crohn's or ulcerative colitis will mount an elevated CRP. Sometimes a quarter to a third of people won't mount a CRP response, but it's something that should be checked. And I just want to dispel a notion that's out there that there's a blood test to diagnose Crohn's disease, because I've seen people where they say that they've been told they have Crohn's disease based on blood work. Now, blood work might be suggestive that someone has Crohn's disease or ulcerative colitis if they have the right symptoms and their blood work's abnormal. It certainly may be suggestive, but it's absolutely not diagnostic. And there is a blood test that we sometimes use, and it's an antibody against a yeast. And the blood test is ASCA, or ASCA. And if it's significantly elevated, then it means someone may have Crohn's disease. Having said that, it's not 100%, because people with Crohn's disease may have a normal ASCA level. And I've certainly seen people in clinic that people have they have an elevated ASCA level and they don't have Crohn's disease. So this ASCA blood test is often done in the community. And like I said, it can help if there's a bit of a diagnostic mystery as to whether someone has Crohn's disease, but it's absolutely not diagnostic. So blood test is a good initial screening test if someone has symptoms, where we can look at all of these things and see if they're abnormal. Now, if it's all normal, that doesn't mean someone doesn't have Crohn's or ulcerative colitis, because again, it's not 100% of a marker. It may mean it's less likely if someone has symptoms and their blood test is normal that they have IBD, but it absolutely doesn't rule it out. Next up are stool tests. And stool tests are important because, as I mentioned earlier on, when someone has an infection, they're going to have similar symptoms to when someone has Crohn's disease or ulcerative colitis. So when someone initially presents with, let's say, bloody diarrhea, we want to make sure that there's not an infection there. Now, if the symptoms are there for a while, it makes an infection less likely, but we still want to rule out an infection. And one of the most common infections that we worry about is called C. difficile, which often occurs after someone's on antibiotics because it changes the microbiome or gut bacteria in their colon, and it allows this C. difficile bacteria to rapidly divide and cause an infection. And some parasites as well, especially if there's a history of travel, that can also cause diarrhea. We'll discuss fecal calprotectin in a bit, but fecal calprotectin is this newer test, and it actually wasn't around 10, 12 years ago. So it's actually great that it's there for patients now, because it's this marker that in fact can show if there's inflammation in the gastrointestinal tract, and we'll touch upon that in a few slides. Endoscopic procedures are really the gold standard, and anyone who's being diagnosed with Crohn's disease or ulcerative colitis certainly has had a colonoscopy at some point in their journey. And the reason it's the gold standard is because it lets gastroenterologists look directly at the digestive tract. And so we can see if there's inflammation there, we can see if there's ulcers, and we can also take biopsies. And that can also help us if there's any diagnostic mystery as to what's going on. Sometimes we do gastroscopy too. So a colonoscopy is a camera up the anus into the colon. A gastroscopy is a camera test down the mouth into the stomach. And then a capsule endoscopy is basically this capsule or pill with a camera at the end that someone swallows and goes all the way through the small bowel. And then finally, imaging shows the deep layers of the bowel. So when someone undergoes a colonoscopy, we can only see the bowel wall, of course. We can't see through the bowel wall. But a CT scan, MRI, even ultrasound, that can show the deep layers of the bowel. So we can actually see through the bowel wall. As I mentioned earlier on, Crohn's disease typically causes inflammation through the bowel wall. Ulcerative colitis doesn't. But in someone with Crohn's disease, we may want to see if there's any damage or any further inflammation. And so that's how imaging can help too. So why do we do these testing? And let's say someone gets diagnosed with Crohn's disease or ulcerative colitis. Why do we continue to do testing? Now, this is a bit more relevant in someone with Crohn's disease, but what we've seen in studies is that as someone is diagnosed, there's this early window of opportunity. And as we see, the inflammatory burden is often typically very high at the time of diagnosis. And we think that if we can get that inflammation down and keep it down, then we can prevent downstream complications from occurring. Some of those complications may be a fistula or an abscess, and we talked about how fistulas are little tunnels or connections between organs that shouldn't be there. Perhaps a stricture, and a stricture is a narrowing in the bowel, and over time it might get so narrow that food can get stuck, or someone may have symptoms and they may eventually need surgery. And that's obviously a complication we want to avoid in someone with Crohn's disease. And so why we continue to monitor people with Crohn's disease is because we want to decrease that inflammation. We know that in people with Crohn's who feel completely well, 50% of these people will still have active inflammation. So historically, we used to just be happy that people were in clinical remission and feeling great. And while that's fantastic, we also want to make sure that there's no inflammation in the bowel, because even though someone feels well, if we let that inflammation linger and continue, we know that eventually they will develop a complication. And so that's where this window of opportunity occurs. If we can get the disease under control early and keep it under control, then the hope is that we will prevent these complications from occurring later on. And so that's why we continue to do testing. Even if someone's in remission, we may continue to do colonoscopies, even fecal calprotectin, imaging with CT or MRI or ultrasound. And so this is the rationale for testing. Even if you're diagnosed initially, we continue to monitor things so that we can decrease this inflammatory burden and hopefully decrease any complications that may occur. So what is fecal calprotectin? And like I said, it's a newer test, which is great because it really has helped in the treatment of inflammatory bowel disease. So calprotectin is actually a protein that is present in certain white blood cells. And white blood cells are the cells that make up most of our immune system. And whenever there's inflammation, the white blood cells travel to the area of inflammation to try and fight off whatever might be there. So when there's inflammation in the gastrointestinal tract, these white blood cells will travel there and they release their contents. So calprotectin is a protein that gets released into the gastrointestinal tract, and then it is excreted out with stool. And it's actually a very simple test because it spits out a number. So when someone does a fecal calprotectin test, it gives a number, and the higher the number, the more inflammation there. And so our goal is, of course, to get as low a number as possible. And this test is essentially done similarly to other stool tests for an infection, but there's a newer way of doing this test on a cell phone where you can actually take a picture of the test at home, and you don't have to take it to a lab or mail it to a lab. Whereas obviously, if you're doing a stool test for an infection, at least not yet, you have to take it in. You can't do the test at home. You have to take, or you do the stool test at home, but you have to take the container to a lab. But some calprotectins, you have to take it to a lab, but others you can do at home on your phone. And why this is important is because it's an easier way to monitor for disease activity as opposed to doing a colonoscopy, and especially in people who are in clinical remission or feel perfect. If they have a normal fecal calprotectin, then sometimes that you can avoid a colonoscopy. Before fecal calprotectins were around, the only way to really know if the bowel was healed was to do a colonoscopy, and that unfortunately can be burdensome and it's obviously uncomfortable. So some people can avoid a colonoscopy if their calprotectin is normal. Now, fecal calprotectin is a test that's at least a bit better of a marker in ulcerative colitis. We see that it mirrors bowel wall inflammation in the colon a lot better. And so it's used a lot more in ulcerative colitis. If there's inflammation in the small bowel and someone has Crohn's disease, it's less useful of a marker. It may be high in people with small bowel Crohn's disease, but many times it may not be. And if it's not high in someone with active Crohn's disease, then it's not a good test to monitor for inflammation. So it's not the right test for everyone with inflammatory bowel disease. And sometimes even having a baseline can help initially as to whether it goes up with inflammation or not. But at least in people with ulcerative colitis, it's a newer test that we know has really dramatically changed how we manage colitis. And I just wanted to touch upon this study because it actually shows that when fecal calprotectin is monitored in people and drops, it's a good predictor of an endoscopic response. And so this was looking at people on vedolizumab or Entyvio with both Crohn's disease and ulcerative colitis. And on the right, it looked at people with Crohn's disease on Stelara. And they showed that when fecal calprotectin was monitored early on and dropped, it was a good marker of, or good predictor of those who responded. And so that's why we may do it early on, because if we see it still high, it gives us an opportunity to perhaps optimize treatment. And we'll get to that a bit later, but as I mentioned earlier, we want to optimize treatment early in people with inflammation. And if we can tell that there's still inflammation, we can optimize earlier by either changing therapy or reducing the frequency of therapy. Next up, we're going to discuss a colonoscopy. And colonoscopy essentially is a long tube with a camera and a light at the end. And I wanted to show this picture because this way people can see where the parts of the colon are, because we always use these terms and it can be very confusing if one doesn't know the anatomy. But the cecum is the very end of the colon, and that's where the termina ileum, or the small bowel, joins. And then you have the ascending colon, transverse colon, and descending colon. Now, commonly with a colonoscopy, the goal is to get to the cecum and then into the small bowel. That's not always possible in everyone. Sometimes it can be difficult to get into the small bowel. Sometimes there could be a stricter or narrowing, which prevents that from occurring. But that's the goal with a colonoscopy. And with a colonoscopy, for those that have never had one before, the hardest part, I'm sure has been discussed, is the prep. And why is a prep done? Well, prep is done because we want to get a clear view of the bowel. When we perform a colonoscopy, it's very hard to visualize the mucosa, the lining of the bowel wall, if there's a lot of poop around. And we can't really assess if there's inflammation present. And secondly, we wouldn't be able to see if there's any polyps or precancerous changes. So you can see on the left picture how an unprepped colon may make it difficult to see what we want to see, if there's inflammation or not, or if there's any precancerous polyps. Whereas on the right side, it's a clean colon, and it makes it a lot easier for the endoscopist. It's also easier for the patient because we don't have to use as much air or water around, and that makes it more comfortable for them too. So there's two parts involved with a prep. The first part is drinking only clear fluids, and that's typically the day before, and then an over-the-counter laxative, which, like I mentioned, is meant to clean out the bowels and meant to give someone diarrhea so that their colon is clean when we take a look. So someone comes to the hospital, let's say an hour before their test. Typically, there's sedation that's given intravenously, and the main medications we use for sedation are intravenous midazolam and fentanyl. And if someone has an anesthesiologist, they may be given other sedating medications. The test itself can be anywhere from 20 minutes to an hour. And afterwards, the recovery time typically is 30 to 60 minutes, sometimes longer. And if you do get sedating medication, you will need a ride home afterwards because they won't let you drive home legally. You're not allowed to drive 24 hours after receiving these sedating medications. I wanted to discuss a flexible sigmoidoscopy because sometimes that's performed instead of a colonoscopy. And you may ask, well, why is that the case? Well, flexible sigmoidoscopy is often performed to visualize just the left side of the colon. And there's benefits to this. People don't have to drink an entire jug of laxative to clean out their entire colon. The only prep that one has to take is an enema the morning of the procedure. So that's a lot easier to tolerate, of course. And the procedure itself isn't as uncomfortable because one doesn't have to go around these two corners, and that can be very uncomfortable for patients. The downside, though, is that you can't visualize the entire colon. So if someone just has ulcerative colitis affecting the lower part of perhaps a rectum or even the sigmoid colon, and even in some people descending colon, and you only want to see the left side of the colon, then you may do a flexible sigmoidoscopy instead. Now, the prep may not be as great because there's just an enema given. So if you're trying to detect polyps, you may not do a flexible sigmoidoscopy. But it is a good alternative test if you don't have to visualize the transverse colon, the ascending colon on the right side, or get into the small bowel. And a capsule endoscopy is this newer test, and also similar to calprotectin, in the last 10 to 15 years, it's become a lot more widely available. And why this is important is because there's a lot of small bowel we can't see. So you may do a scope down the mouth and you can see the first part of the small bowel. And then on colonoscopy, like I mentioned, ideally you can get into the small bowel as well. But there's somewhere between 300 to 500 centimeters of small bowel in between that we just can't access by endoscopy. And so that's where a capsule endoscopy may come into play. And it essentially is a capsule or a pill with a camera and light at the end. And what one does is they prep the day before, sometimes just clear fluids, sometimes a bit of laxative as well, to make sure that there's nothing in the small bowel. And the person comes to the hospital in the morning and they swallow the pill, and they wear what's called this recorder, typically on their belt. And as the pill goes through the small bowel, it transmits images to the recorder. And the next day, they bring the recorder back and download the images onto the computer. The pill does not have to be retrieved. So that exits through the poop, and the patient does not have to retrieve it. So this is a really good way to visualize a small bowel. If we think there may be something missed, or if someone's still having symptoms and we can't yet explain it by what we see on colonoscopy, this is a way to see if there's any other inflammation or lesions higher up in the small bowel that may be there. So the benefit is it's painless, there's no sedation involved. It's not great for everyone though, because if someone has a narrowing or stricture, then there is a risk that this capsule could get stuck, and that could rarely, but it can lead to a perforation. So if someone has a history of a stricture, what is often done first is an agile capsule. And an agile capsule is a similar size, but it will disintegrate in the bowel in 48 hours. So you do an X-ray shortly after swallowing it, typically a day or two, and you see if there's still a capsule there. And if the agile capsule is still there, you don't move on to the formal video capsule with the actual pill and camera. If it's not there, we know that the capsule can pass through the small bowel and the person can have a formal video capsule. So next up, we'll discuss imaging tests. And there's a few different imaging tests available. So CT scans, MRIs, or ultrasounds. And like I mentioned, these are good ways to look through the bowel wall. And so if we want to see if there's a narrowed area in the bowel, such as a stricture, this is one way to assess it. You may see a stricture on a colonoscopy, but it may be hard to get through with the scope, or you can't quite see how long the stricture is, and that's where this can be helpful. There could be fistulas, which, as I mentioned, are tunnels between organs that shouldn't be there, and you really can't see that on endoscopy. And if there's an abscess or an infection, you won't see that on endoscopy. So that's where an imaging test will be helpful. Typically done more in Crohn's disease, sometimes in people with ulcerative colitis, but typically more in people with Crohn's disease. So ultrasound is certainly a newer modality that's used, and it's non-invasive, it's easy, and basically you just need to put the ultrasound probe on the abdomen, and we can see if there's any bowel wall thickening that's present. And so it can help guide treatment response and help guide us as to whether treatment optimization has to occur or not. It's starting to be more popular. It's certainly not in every center, but it's certainly becoming more popular in treating people with Crohn's disease. CT scans and MRIs have been used for decades. And what a CT scan is, for those that don't know, is it's essentially a donut-shaped scanner, and the person lies down and goes through the scanner, and it takes numerous X-rays to create images of the inside of your body. Now, the benefits is it only takes a few minutes, and it's widely available because the machine can do so many more tests than an MRI. And because of that, the wait list is shorter. The drawback, however, is it does involve radiation. Now, if someone has many CT scans over their life, there is an increased risk. It's not a lot, but it's slightly increased risk of complications, and usually that's cancer. But it is rare, and one needs to have a lot of CT scans. So typically, CT scans are safe and they're done all the time. In younger people, though, if we're trying to avoid radiation because we know they may have more imaging in the future, that's where an MRI might be helpful. So an MRI is this large enclosed tube, and someone lies in there. And the benefit is there's no radiation, but the drawback is it's a longer test. It uses essentially magnets, and it's anywhere from 10 to 30 minutes as opposed to a few minutes. So for this reason, the wait lists are longer. The machines are a bit more expensive, so they're not available everywhere, but they can be helpful as well. Now, there's a special type of scan, either a CT enterography or MR enterography. And these are advanced scans that take detailed pictures of the small intestine. And why that's important is because normal CT scans or MRIs aren't great at looking inside the gastrointestinal tract. But what a CT or MR enterography involves, both intravenous and oral contrast. And what the oral contrast does is it essentially inflates the small bowel so that we can see inside of it. And that allows the radiologist to see if there's any inflammation. They can assess if there's a polyp or some sort of small bowel pathology, or if there's a narrowing like a stricture, and even the fistulas and abscesses. You can still see these on CT scan, but not great. So that's where your gastroenterologist might order this dedicated enterography scan. So those are the majority of tests that are done in people with inflammatory bowel disease. And I always think it's important for patients to understand their tests and their test results. And it's important that once these tests are done, you know how it's involved in your care. So certain questions that you may at least think of or ask your gastroenterologist was, number one, what is this test? What did it measure? And what did it monitor? Like I said, if they're doing a CT scan or an MRI, perhaps they're looking for a stricture, perhaps someone has a history of fistulas or an abscess in the past and they want to see if that's there or not. Or if it's a fecal calprotectin, they want to see if there's inflammation in the gastrointestinal tract. Number two, was this test normal? So again, if they have a fecal calprotectin and your gastroenterologist tells you, what the result is that good? And even if it's not normal, maybe in this case, it's appropriate because we just want to see a certain response. So that's where it's important to ask your gastroenterologist if a test is normal, what's considered normal, and if that test is appropriate for you, because oftentimes we do tests to change management. And so if the test is abnormal, is that going to change the current therapeutic regimen? So I've gotten this test back, doctor. How does this change anything? And maybe it doesn't. Perhaps the test is normal and everything looks good and we continue everything the same. But if it doesn't, it's always important to ask how that's going to change your therapy. And then finally, when's the next test? If you've done a fecal calprotectin and it's normal, are we going to do another one? Is it 6 months, a year? If you've had an MRI, are we doing another one? Perhaps not. Maybe one-time scan is all the gastroenterologist was looking at, but many times you may have repeated tests in the future. So it's always important at least to bring it up and get the discussion started. So these are treatment goals in people with inflammatory bowel disease. And I wanted to discuss this because it's based off the STRIDE guidelines as to how people with inflammatory bowel disease, essentially what our goals are. And short term, we have a few things. We want patients to start feeling better. And of course, they may not feel perfect, but we want there to be a response. When someone started on treatment, we want initially in the first few months for their symptoms to improve. We also want to see their test results improve. And that can either be by imaging, fecal calprotectin, or even endoscopy. We want to see some sort of improvement. We can even do it on blood tests. And as you may know, CRP can be elevated, as we talked about, not everyone, but many patients can have an elevated CRP, and perhaps just monitoring that may be appropriate. And of course, quality of life, we want to see improved as well. Intermediately, though, we want to see symptom remission, meaning someone feels back to normal and they don't have any symptoms. And we also want to know the gut lining is healed. And those are really the two main goals when treating inflammatory bowel disease. We want people to get back to their normal functioning baseline, get back to their life, not have to think about their Crohn's disease or ulcerative colitis on a daily basis. But even though they feel well, we want the inflammation to subside too, because we know even if someone feels well, but there's ongoing inflammation, that over time, complications can still occur. So those are our two main goals. And with that, quality of life and psychosocial health also improve. Longer term, we of course want any disability that may have been present to be reduced and be absent. And we want longer term complications to be absent as well. So dysplasia is essentially precancerous changes, and that is a concern in people with inflammation in the colon, be it from ulcerative colitis or Crohn's disease. And we want to avoid surgery as well. And that's why I talked about early on this early opportunity window when people are diagnosed and how we want to get that inflammation down, and we want to keep it down the entire time so we can reduce these complications that can occur. So how do we do this? Well, one way is treat to target. And this is a strategy where instead of waiting for symptoms to return, we do testing regularly. So first off, the patient will discuss treatment with the gastroenterologist. And there should always be a plan. When you're starting treatment, what's our plan? What's our goal? And so most of the time, the goal, like I mentioned, will be getting you feeling back to normal and getting the inflammation to go away. So when you start treatment, we want to see if the treatment's working. How are we going to do that? What tests are going to be used to assess that? We can do stool tests, endoscopy, imaging, but there should be a plan in place that we monitor the disease. Are we going to make any changes if needed? So if someone is, let's say, on Entyvio or vedolizumab, and they're receiving it every 8 weeks, if after a few months they're not quite in remission, are we going to increase it to every 4 weeks based off a stool test? And if that's done, we're going to recheck their progress. So if someone's Entyvio is reduced to every 4 weeks, what are we going to do next? We're going to, let's say, check another fecal calprotectin. And then if it's normal, we know our target has been reached, but we're going to keep monitoring because we know that some of these tests can show inflammation even before you may have symptoms. And that's really another reason why we do this testing, because even though one feels well, when there's still inflammation there, they may develop symptoms over time. And we want to avoid that. And so by having this treat to target, we can hopefully reduce that from occurring by keeping our management strategy in place. Again, our goal is low or ideally no inflammation that's there. So briefly, I just want to discuss the role of precision medicine in IBD. And this really is the holy grail, because knowing what treatment to use in what type of patient still eludes us. We do have some idea as to when to use some therapies, but it's not perfect yet. And so there's a lot of research going into this idea of precision medicine. We do know that there are some risk factors for both ulcerative colitis and Crohn's disease that, of course, put people at higher risk of complications. And so in the red area for ulcerative colitis and red area for Crohn's disease, if someone has any of these features, we consider them higher risk, and we may be a bit more aggressive in their treatment for that reason, because we know they're at risk of downstream complications. Now, there are challenges with treatment order, and I think it can be very frustrating for patients that they know that there's lots of therapies available now, which is fantastic, but there can be confusion as to which therapy is used. And why that may be difficult is because IBD looks different in every person. As I mentioned before, there's so many different ways Crohn's disease and ulcerative colitis can present. It's difficult to treat people similarly. And so the trials, of course, include people with Crohn's disease or ulcerative colitis, but we know that not every disease behaves the same way. We also can't predict who a treatment will help. So we know that some of these treatments will get anywhere from 30 to 50% of people in remission. Why those 50% or 30 to 50% respond and the other 50 to 70% don't respond, we don't quite yet know. And we don't understand that once a treatment works, why over time it may stop. And there's something perhaps either in the body or the immune system that goes around that treatment that causes inflammation. We don't understand why. So that's another difficult aspect for gastroenterologists. And it's hard to compare treatments. We have a lot of treatments available, but there's only a few head-to-head studies showing what's better than, or what medication may be better. And so we don't really know. We can try and compare randomized trials, but it's not ideal the way that's done. And so while we have an idea what may work better, it's hard to know what can in certain people. And again, the research on the order also is lacking. So we often know what can be used first line in some people, sometimes second line, but after that, sometimes it's difficult to know because, again, there's just not a lot of research in this area. Now, we do know there are certain factors that can lead us to choose one therapy over the others. So there's certain personal factors such as age or comorbidities. If, let's say, someone's older and is prone to infections, we may choose a therapy that doesn't affect the immune system as much. We know that in certain people and females who want to get pregnant, there are some therapies we may want to avoid. And if someone has a coexisting immune condition, such as psoriasis, then we have therapies that can treat both the inflammatory bowel disease and the psoriasis. We also know that patients themselves prefer certain administration. So some of our therapies can be given intravenously, some subcutaneously, and some are oral therapies. And so some people may have a preference for that. And there has been evidence that in some people with limited small bowel Crohn's disease, surgery as first line is an option too. So it's not typically done here, but that is an option for some patients. Finally, we know that certain disease considerations can play a role in what treatment is used. So in someone with perianal fistulizing disease, we know that anti-TNF therapy, such as infliximab or adalimumab, has the best evidence in these people. And so we try to use these therapies first. There are certain extraintestinal manifestations. So if there's inflammation outside of the bowel wall, such as in the skin or the joints, that may also help us in deciding a certain therapy. If someone's had Crohn's disease and had surgery, again, that may help us choose a certain therapy. And then if they've been on prior treatment in the past. And so all of this can help us decide which therapies. But again, we don't know 100% which therapy will work best. We have an idea what should be used, but that's not always the right choice. And ideally, in the future, we'll be able to get a sense as to what may be used. But again, we're not there quite yet. So in conclusion, I hope everyone has a better understanding of the different tests that your gastroenterologist has at their disposal to help both diagnose and monitor your inflammatory bowel disease. And I do think it's important that patients understand the purpose of these tests and how it changes your management. I really do feel that it's important that patients stay engaged and stay informed and educated about these different tests, why they're being done, and how it's gonna affect their care, because I feel that taking these steps, patients can take better control of their inflammatory bowel disease care. So thanks, everyone.
Okay, awesome. Thank you, Seth, for sharing the information. That was really helpful. Before we proceed to the Q&A portion, I'm just going to launch the post webinar poll, and I'll give everyone about 30 seconds to reply. The capsule endoscopy is really cool.
Yeah.
Well, that's very innovative.
Yeah.
Okay. All right, I'm going to end the poll. Thank you, everyone, for taking part in the poll. I will also share my slides now, and then we'll go over the questions that were submitted during the registration, and Dr. Seth Shaffer will answer them. Okay. Oh yes, again, the disclaimer is the questions that we're answering today, they're more general and they're not about specific medical situations. Okay. So I'll begin. So the first question we got was, can you comment on the presence of pseudopolyps with mild dysplasia?
So pseudopolyps are, as the name confers, they're polyps. They're outgrowths in the colon, but they're not true polyps. True polyps are essentially those that have are precancerous or have cancerous potential, and it may be years or decades before it could turn into cancer. But pseudopolyps are polyps that occur when there's chronic inflammation and there's no cancerous development of these pseudopolyps. So there typically shouldn't be dysplasia. And dysplasia is a term that's used to describe precancerous changes. If there's dysplasia in a pseudopolyp, I mean, it should be removed. I think the question's talking about dysplasia in the colon when there's pseudopolyps, because pseudopolyps can make it difficult to look for true polyps. It's almost like it's just very difficult to find. And so intensive screening should be used. Sometimes, though, people with colitis who have a lot of pseudopolyps, if they do have dysplasia, which we know over time will develop into cancer, they may need surgery. But that can be oftentimes there should be intensive screening to make sure that this dysplasia is removed, that there's no other cancerous lesions present. But the pseudopolyps themselves, we know won't turn into cancer. And the presence of pseudopolyps, I was involved in a study actually some years ago, we showed that there's no increased risk of cancer in those with pseudopolyps. So it shouldn't scare you if you do have pseudopolyps. Having said that, if there are precancerous changes somewhere in the pseudopolyps, it certainly can be very difficult to manage.
Thank you. The next question is, other than disease activity or a flare, what can increase fecal calprotectin levels?
Well, that's a good question. So we know that calprotectin levels increased when there's inflammation in the gut. And so the other thing we think of, if not from the inflammatory bowel disease, if there's an infection present. Now, it's thought that in some people, certain medications such as NSAIDs, which are ibuprofen or naproxen, that may raise levels, but not significantly enough. PPIs or proton pump inhibitors, also the literature says can increase it, but typically, if a fecal calprotectin is significantly elevated and someone's having symptoms suggestive of a flare, we wouldn't think it's a medication. We would think either it's the disease itself that's active or there's an infection present. If there is a concern that it's something else, then of course you would just stop that other thing and repeat the calprotectin. But I have to say it's almost always either from the disease itself or, like I said, from an infection that may be present.
The next question is, what is the definition of a flare? I'm guessing they mean clinically. Is it based on symptoms or fecal calprotectin numbers?
Typically based on both. And so you don't necessarily need a fecal calprotectin test if someone's having a flare. Having said that, there should be some objective marker if someone's having new symptoms just to document that it's not something else. So other things that can cause symptoms that may mimic a flare could be a new medication that's started. There's certain medications that can cause diarrhea. Even just the presence of stress and anxiety, we know, can lead to symptoms, and it can also lead to a flare, but it can also lead to symptoms without active inflammatory bowel disease. So there's no specific threshold for where one might define a flare or not. It's typically just an increase in symptoms, which most often is increase in bowel movements with abdominal pain, perhaps the presence of blood. Now, fecal calprotectin can help, of course, differentiate active inflammation from something else, but it's not necessary that a fecal calprotectin is done. A normal fecal calprotectin, like I said, the lower the number, the better. Having said that, clinical trials tend to use 250. And so anything 250 or less, we consider normal.
A lot of fecal calprotectin questions. So next question is, is fecal calprotectin a good tool for monitoring remission status, and how often should it be used?
Absolutely. So fecal calprotectin is a fantastic way for monitoring remission. Like I mentioned, though, it's better for monitoring ulcerative colitis and Crohn's disease. If someone has Crohn's disease, and even when they've had active disease, their fecal calprotectin has not increased, I wouldn't use it because we know it's not going to go high if they have active disease. Having said that, if it does increase when they have active disease for their Crohn's or in the small bowel, I would use it for monitoring remission status. But it is a much better test for ulcerative colitis, and absolutely it should be used to monitor remission status. How often is a bit of a judgment call. Typically, if someone's feeling well, you can say every 6 months. Some doctors may prefer, 3 months if there's a treatment change or some other reason. And if others have been in remission for years, some gastroenterologists may only order it once a year for just monitoring purposes. So it's a bit of a judgment how often it should be used.
The next question is, for Crohn's exclusively in the small bowel, can ultrasound be used effectively to assess disease activity, monitor treatment response, and detect complications? If so, why isn't it offered as an easier alternative to video capsule endoscopy?
Ultrasound is definitely an exciting new treatment that's available for small bowel Crohn's disease. There's still studies ongoing as to how and when it should be used, but the data that's out there shows that it's excellent in helping people with Crohn's disease. Why is it not offered as an alternative? I think that's a great public policy question. I wish we had more resources at our disposal. And in some centers it is, it's just not widely available or as widely available as we'd like.
What does a diagnosis of IBDU mean? I was told it's neither Crohn's disease nor ulcerative colitis.
So IBDU essentially is IBD unclassified, and it's if someone has features of both Crohn's disease or ulcerative colitis. Now, typically it's just in the colon because if there's any small bowel inflammation, by definition, that's Crohn's disease and not ulcerative colitis. But if they have features of ulcerative colitis, but not typical, and it also has features of Crohn's disease, the gastroenterologist may just use that IBDU label as opposed to either Crohn's disease or ulcerative colitis. It doesn't necessarily change anything. The treatment is roughly the same. I mean, it won't change treatment or prognosis, but it just means that I guess the absolute diagnosis is a bit of a mystery. Sometimes over time, it can declare itself as either Crohn's disease or ulcerative colitis, but essentially the treatment won't be any different.
How accurate are fecal calprotectin tests?
Great question. Very accurate. The sensitivity and specificity, and those are just statistical terms that we use for certain tests to help rule in or rule out inflammation. It's over 90%. Now, it's higher again for ulcerative colitis than for small bowel Crohn's disease, but it's very accurate. It's over 90% predictive of inflammation. If someone feels well and their fecal calprotectin is high, which we sometimes see, then you may want to repeat the test. And if it's still high, that's where you may want to do an endoscopy and actually see, is there any inflammation there? Alternatively, if someone's feeling poor and has symptoms, but their calprotectin level is normal, you may also want to do a colonoscopy, because if there's that discordance between symptoms and calprotectin levels, that's where you want to do further testing to really see, is there inflammation present or not? So fecal calprotectin is a good guide. It's not a replacement for endoscopy, but it's certainly a good guide to tell us if there's inflammation that's present.
Okay, next question is, how can I advocate for myself regarding other IBD symptoms that many gastroenterologists seem to overlook, like mental health, hair loss, or tingling in fingers, since the focus is often on bleeding or bowel frequency?
I think that's a great question. There's a lot in IBD outside of just the bowels, and we know that mental health is extremely important, and the rates of stress and anxiety and mental health disorders is higher in people with IBD. And as this person mentioned, there can be other symptoms as well. I think it's important to always bring it up, and if the gastroenterologist is not listening, then asking for to see other members of the healthcare team, be it a dietitian, mental health provider. Sometimes they can help navigate other areas or other symptoms that may be present. But I always think it's important for patients to advocate for their own health in this instance.
Sure. Okay, medications with question slightly worded differently, but I think the question is essentially, what are the short-term, medium, and long-term future of regarding personalized medicine?
That's a great question. Short answer, I don't know, because it's not here yet. there's a lot of research trying to understand how we can personalize therapy for people. We've seen it in oncology that they test certain receptors and the oncologist knows what chemotherapy to use or what the person will respond to. We just haven't seen that type of breakthrough in inflammatory bowel disease yet. There's a lot of research going into it, whether it's something in the blood, a blood test, or even in the stool, if there's some sort of bacterial signature, but we're not quite there yet. So I'm optimistic that it will be coming, but we don't have any answers yet, unfortunately.
I'd love to understand more about how nicotine interacts with ulcerative colitis. I've had success with the nicotine patch in controlling inflammation better than previous medications.
That's a great comment. Nicotine has been found to be helpful in ulcerative colitis. So smoking actually can be protective against ulcerative colitis, although conversely, smoking is awful for Crohn's disease. We don't really know why. We know that nicotine may have some anti-inflammatory properties, although obviously not for Crohn's, but for ulcerative colitis. It's thought that nicotine can lead to nitric oxide release, and that can help smooth muscle, relaxant, essentially just relaxing the colon. So it can help symptoms that way. We do know that in people who smoked cigarettes and then stopped smoking, actually there is an increased risk of ulcerative colitis compared to people who continue smoking. But we would never advocate smoking as a treatment, of course.
Interesting. Okay. What blood test results should patients monitor that may not immediately raise red flags?
Well, the blood tests that we discussed earlier, I think, are all really important. It's the CBC, so the hemoglobin and white blood cell count, ferritin, which is a marker of iron store, and that's good to see if someone's deficient in iron or not. I think albumin is an important blood test because it should be normal, and if it's low, then it may indicate that there's chronic inflammation. And we've talked about C-reactive protein as well. So those are the main tests that should be done on blood work.
What should be done if tests show endoscopic remission, but the GI dismisses extraintestinal symptoms like severe fatigue?
Fatigue, unfortunately, is very prevalent in IBD, and it's present in roughly half of people with Crohn's disease or ulcerative colitis. And it's always important to try and find the underlying cause. So, of course, if there is active inflammation, that can be a cause of fatigue. We should always rule out nutritional deficiencies. So, a low iron, B12, those should be done as well, and even other coexisting diseases such as thyroid disease should be looked at. And if all of those are normal, I mentioned before, mental health disease and disorders and stress and anxiety are much more prevalent in inflammatory bowel disease. Those itself can cause fatigue. We know that proper sleep hygiene in people who don't get enough sleep, that can cause fatigue. The medications themselves, some of them have fatigue as a side effect. And even after doing a thorough check and not finding a cause, unfortunately, fatigues can still be present in people with IBD, and it can be a very frustrating symptom to deal with.
Okay, this is a two-part question. So the first part is, can IBD be misdiagnosed even after major tests? And the second question is, why are routine tests, such as blood, urine, or stool, still necessary during remission if you feel fine?
So can IBD be misdiagnosed? It can be. I mean, it's hard to know what specific situation it may be. There are some mimics of IBD. These are more prevalent in older people, the mimics of IBD. So we know that if someone has other causes of inflammation in the colon, so if there's ischemia or low blood flow, if someone's had radiation therapy for prostate cancer or cervical cancer, that can also induce changes in the colon and cause inflammation. And if someone has diverticulosis, which are benign outpouchings, and it's more common in older people, sometimes there can be inflammation surrounding these outpouchings in the colon, the diverticulosis. There can be this type of colitis around diverticulosis. So in the elderly, it can sometimes be difficult to diagnose IBD or perhaps be misdiagnosed. As for the second question, I hope I answered why routine tests are still necessary during remission, because we know even if someone's feeling well, there's a chance that there's ongoing inflammation, and the risk of leaving that inflammation in the gastrointestinal tract unchecked just puts someone at higher risk of complications. So chronic inflammation anywhere in the body, but especially in the gastrointestinal tract, it's a risk factor for cancer. So even in the small bowel, we can see small bowel cancer. It's rare, but we see that it's increased in people with Crohn's disease, and especially in people with inflammation in the colon. Over time, it's a risk factor for cancer. So that's why gastroenterologists continue to do these tests and perhaps even change therapy, because clinical remission is only half the battle. We also want to reduce that inflammation to reduce long-term complications.
Thank you. The next question is asking for information around the validity of calprotectin in the context of constipation. And the second part is, if calprotectin is elevated and the patient has an infection, how long should we wait before repeating the test?
Great question. In terms of constipation, I mean, that shouldn't affect the calprotectin too much. Sometimes it can, but if someone has known Crohn's disease or ulcerative colitis, it shouldn't affect the calprotectin enough where it's not a good marker of gastrointestinal inflammation. So it's still valid. If someone has constipation, you can still do a calprotectin test. If it's elevated and it's found to be from an infection, there's no right amount of time to wait. Of course, you want that infection to go away. And once your symptoms are back to normal, perhaps waiting a few weeks and then repeating the test should be fine.
The next question is, do you still have colitis if most of your bowel has been removed and you have a stoma bag?
That's a great question. So if someone has a colectomy, meaning that their colon's removed, and they have an ileostomy, where it's their small bowel going to their stoma, one way of looking at it is the ulcerative colitis has been cured because the colon isn't there anymore. So one may not have colitis any further, but they still have inflammatory bowel disease, if that makes sense. So they can still get complications of ulcerative colitis. So we know that ulcerative colitis, or people with ulcerative colitis, can get inflammation in the skin, in the joints, in the eyes. And so if someone has a colectomy, they won't get colitis, but their IBD is still there and may still cause issues down the line.
Another question about fatigue. Is there anything that can be done for persistent fatigue?
That's a great question, and fatigue is a very frustrating symptom, like I mentioned. I think it's important that other potential causes of fatigue be looked at and not be ignored. Nutritional aspects, like I mentioned, iron, B12, and there's other nutritional tests that can be done, the medication themselves, and even just having Crohn's disease or ulcerative colitis, even if it's in remission, can cause fatigue, like I mentioned. But mental health symptoms, it's always important to make sure that there's not underlying mental health symptoms, because that by itself can also cause fatigue. And I really do think sleep as well. I think poor sleep can certainly cause fatigue, and with the ever-growing technology and smartphones and laptops that we're always on, I think contributes a lot to poor sleep at night. And so other things should be looked at, but unfortunately, persistent fatigue is certainly still a frustrating symptom once those have been ruled out.
Mhm. Okay, so that's the last of the questions that we received through the form, but Dr. Shaffer, if you're okay with it, we received some questions during the seminar.
Great.
So we have about 10 minutes if you're okay. I'll try to go through some of the questions. Do you briefly want to talk about the role of fecal transplants, fecal microbiome transplants in ulcerative colitis?
That's a great question. So fecal transplant essentially is transplanting or using the poop of someone else and putting it into someone else's colon. Now, it's been shown to be extremely helpful in people with recurrent C. difficile infection. And I talked about C. difficile infection before, where that's an infection typically after one is on antibiotics, and that can shift the microbiome in our gut. And C. difficile can then rapidly reproduce and cause an infection. And in these people, if you then transplant stool or feces from someone else into them, the cure rates are upwards of 90%. And so that's been shown to be beneficial. Now, why might it be beneficial in ulcerative colitis? We know that the microbiome is different in people with ulcerative colitis. So in fact, a healthy microbiome is a very diverse microbiome. The more and variety of bacteria present actually is better. And in people with ulcerative colitis with inflammation, there's less diversity of their bacteria. Now, it's a bit of a chicken and the egg. Does the change in the bacteria in the gut lead to inflammation, or does the inflammation then lead to a less diverse microbiome? And so the thought process was transplanting someone with a healthy microbiome into someone with ulcerative colitis may be a treatment. Studies so far have shown an improvement over placebo, but not enough that it's in the mainstream right now. So it's still in the investigational phase. And one of the reasons is not every microbiome is the same. There may be some people who have better microbiomes. And so we don't yet know, what signature that is, what bacteria. There's trillions of bacteria in our colon. There's more bacteria in our colon than there are cells in our body. So it is very complex. I will say, though, there are going to be studies looking at using fecal transplant not as monotherapy, so not as therapy by itself, but in conjunction with biologics. So if someone is starting, I'm just saying, for instance, Entyvio or another biologic, is there a difference in using fecal transplant in combination with that therapy? I don't think the fecal transplant by itself has been shown to be useful as its own treatment, but perhaps in combination with biologic, maybe it's better than just the biologic itself. I'll say also it's very fascinating because the microbiome is this wild west that we're just learning about, that in people with cancer who are starting immunotherapy, which is a type of therapy that uses one's own immune system to attack cancer cells. In people starting immunotherapy for cancer who are given a fecal transplant, they do better than those not given a fecal transplant. And why that affects their cancer therapy, we don't really know, but we know that somehow the bacteria in our gut, it influences our immune system. I mean, we know that. So analogously to ulcerative colitis, perhaps using a fecal transplant in conjunction with a biologic may be something that's used down the line. So it's still in the investigational phase. We know it probably has a role someplace. We just don't know where that role is yet.
And now I'm just going to combine two similar questions that came in. It's about the prep that one has to do for a colonoscopy. So they were just asking, is a full prep always required? And could you share any updates, if there are any updates or improvements available for that process?
Well, I wish I had a better answer, because I know that's always the hardest part and the most frustrating part for patients is drinking the entire jug of laxative. There are alternatives for some people, such as Pico-Salax, although one still has to drink a lot of fluids, but it can be any fluid like Gatorade or juice or water, but it's not appropriate in people with heart failure or kidney disease. So then they would have to use a colite. There are some studies looking at lower volume, so 2 liters of prep as compared to 4 liters. And in fact, I'm involved in a study right now that's looking at using only half the volume of prep in people with inflammatory bowel disease. So there's certainly studies looking at it, but yeah, unfortunately, a full prep right now is still required until we get evidence to show that less is equally as effective.
And Dr. Shaffer, out of curiosity, like how long would it take from the results of that study to then be implemented during clinical care?
Hopefully in a year or two. I mean, we're hoping for the study to be done soon. And, again, it may not be appropriate for everyone if they've had poor preps or people who have constipation that need more prep. But I'm hoping in the next few years it may be an option for people prepping for a colonoscopy, because that's always the hardest part. And I understand why people don't want to undergo repeated colonoscopies.
Yeah, yeah. Another question we got in was, what is a good fecal calprotectin value? Something that shows that the individual is responding to their medicine. And I think the interesting part is they're asking if the number is the same, if that value is the same for adult versus teens.
That's a great question. Every physician may interpret, it differently in terms of certain people may have a baseline as to what their calprotectin is normally. I mentioned earlier that the easy answer is 250, so less than 250 is normal. Having said that, our goal is really to get it as low as possible. And so if someone has a level that's undetectable or less than 100, that's ideal, but it may not be possible in everyone. And we use that 250 threshold. And as far as I'm aware, it's similar for people of all ages. But it can also be used as just a marker. And so if someone has an elevated fecal calprotectin of, let's say, 3,000, and they start treatment, and the next one is 500, that by itself shows us that it's trending in the right direction. So it always has to be put in the right clinical context.
Yeah, makes sense. The next question is, can you talk a little bit more about abscesses and fistulas and how can they be prevented? Is it only with treatment? And are there specific treatment for abscesses?
That's a great question. As far as we know, treatment of an abscess is usually either drained or may have to be surgically drained. If they're small, sometimes antibiotics are used. Can they be prevented? There was a study a few years ago at one of our conferences showing that in people with Crohn's disease who are on aggressive treatment and they get their inflammation down, they're less likely to develop fistulas and abscesses compared to people with persistent inflammation. So as I mentioned, getting people on treatment, the right treatment, and getting their Crohn's disease under control is really the best way to prevent the treatment of fistulas and abscesses.
Okay, so I'm going to just take 2 more questions just because we're almost at we're at 8:30, and I think these would be helpful to the individuals attending today. So the first question is regarding using fecal calprotectin to avoid a colonoscopy. Are there updated guidelines on how often one should be receiving should have colonoscopies to verify for polyps/cancer, given the increased risk?
That's a great question. So when I mentioned that fecal calprotectin can be used to avoid a colonoscopy, that's typically done when we want to ensure that the colon has healed. So when we start treatment, we want to confirm that the treatment's working. And so instead of doing a colonoscopy in 6 months, which used to be done all the time historically, if let's say someone has a normal fecal calprotectin in 6 months, you can avoid a colonoscopy to confirm that the gastrointestinal tract is healed. As for what was the second part? To avoid colonoscopies for polyp detection, unfortunately, it won't. And so we know that the risk of dysplasia or colon cancer increases around 8 years after the diagnosis of ulcerative colitis. And so that's where colonoscopies come into play. Now, in terms of the frequency, that will vary based off the severity of the colitis and how active it's been. In people in remission for years and who've had no inflammation for, let's say, 20 years, you may do a colonoscopy every 3 or even every 5 years. Conversely, if someone's had a lot of inflammation and has required numerous courses of prednisone and has had difficulty staying in remission, you may do it more frequently, perhaps every 1 to 2 years, because we know that their risk of polyps and eventually cancer is increased compared to when the colon is healed. So it will depend clinically how often colonoscopies are done. If there is a history of dysplasia or a precancerous polyp removed, those people certainly will be surveyed more frequently.
Okay, thank you. And then the last question, if fecal cal is very low, clinical symptoms are resolved, and there's mucosal healing confirmed by endoscopy, is it wise to wean off medications, or should one continue to should they continue to maintain remission? What is the risk benefit of de-prescribing?
That's a great question, and I've done some work on in this area, and essentially we call this de-escalation of therapy. And it's a great question because some patients who get into remission may not need to be on therapy, and for whatever reason, whatever trigger caused that inflammation at some point isn't there anymore. And we know that some people can stop therapy and be well for many years. So I agree. I mean, before even discussing de-escalation, you'd want to ensure that the inflammatory bowel disease is in remission. We know that the longer one is in remission, the better the chance they have when stopping their therapy. So if someone's only been in remission for 3 months, I wouldn't advocate for stopping therapy, as opposed to if they've been in remission for years, then that's where you can have the discussion. So I agree. I mean, you would want to do a colonoscopy. Perhaps you would do a capsule endoscopy or imaging if they've had small bowel disease. You'd want to ensure if they've had elevated fecal calprotectin, that's normalized, their blood work. If it was abnormal, it's normal. And that's where the discussion may come in. These therapies we have are very safe. The risk of long-term side effects, while some are present, we know that they're low. And so there's a risk of de-escalating therapy. Now, sometimes that involves stopping a medication altogether. Sometimes that involves just reducing the amount you're taking. So in people with, let's say, inflammatory bowel disease, if they're on infliximab and they're on a very high dose every 4 weeks, perhaps you go down to every 6 or even every 8 weeks. So you're not stopping the medication altogether, you're just de-escalating. And some people who are on combination azathioprine, which is a pill, and let's say they're on adalimumab, which is an injectable anti-TNF, after a year or two, perhaps you stop the azathioprine and just continue the adalimumab. So there are ways to de-escalate without stopping the medication completely. But it is a good discussion, I think, to have. Some people wish to go on a drug holiday and stop their therapy altogether. So if they're on infliximab, they want to stop it altogether. And I think it's reasonable in some people. Having said that, we do know that studies have shown us that after a few years, a large portion of these people will eventually flare. And there's a risk that that medication that worked in the past doesn't work again in the future. So around 20 to 30% of these people may try and restart infliximab and it won't work. And so it involves a discussion that there is a risk of flaring and requiring prednisone and going back on the same therapy. And there's a small chance that therapy that worked before won't work again in the future. So it is important to have that discussion. It's important, like this person mentioned, that they're in remission. There's no inflammation there. We know if there's inflammation there and you stop therapy, invariably they're going to flare. And that even so, if they want to stop the therapy, I think it's a reasonable option. It just should be a discussion that the patient is aware there are risks of stopping medication because there is a chance of flaring.
Perfect. So that concludes the Q&A section. Thank you so much, Dr. Shaffer, for taking the time to answer the
Thanks so much for having me.
Oh, yes, thank you. We're very grateful. Before we head out, if you have any more questions or require further support, please shoot us an email at learn@crohnsandcolitis.ca. And you can also follow Crohn's and Colitis Canada on our various social media platforms. So that's it for today. Thank you, everyone. Thank you to our interpreters, and thank you to, again, Dr. Seth Shaffer for taking the time, and hoping everyone has a wonderful night. Take care.
Thanks.
Bye.